Lots of people are wrong about OCD. Even a lot of mental health professionals are wrong about OCD. It's just hand washing and lock checking. It's a preference for things to be in order. It's being picky. Wrong, wrong, wrong. Or at the very least, incomplete. So by the end of this video, you will understand what OCD really is and what to do about it. So stick around because some of this might surprise you. Hey there, Jessica here. I'm a therapist in Austin who specializes in treating OCD with exposure and response prevention, which is the first line gold standard treatment for OCD, and much more on that later. So be sure to stick around for the whole video to learn what OCD actually is and how ERP can effectively cure it. All right, so where I want to start is just to kind of answer the question, talk about what is OCD. Subtitle, it's more than just hand washing. So OCD entails both obsessions and compulsions that relate to one another in a never-ending loop of distress. So an obsession is usually a thought, but it could be an image or a sensation or a behavioral urge. Obsessions are intrusive, they're jarring, they are always distressing. With OCD, the obsession is either going to make you feel really scared or really disgusted. Obsessions are what we call in the therapy world ego dystonic. So this means they are inconsistent with your values or with who you really are. Also, obsessions tend to be a little more out there than ordinary worries. So an ordinary worry might be, I think I'm getting sick because my throat hurts, or my kid is struggling in math, I hope they pass, or money's tight this month, I hope I can afford the rent or the electric bill. Those are worries. Obsessions are more things like stuff that sounds kind of out there. So what if I ran over a pedestrian without realizing it? Or what if I'm responsible for the whole pandemic? Or are we all dead? Maybe we're all dead. So OCD really likes to kick you where it hurts too. So it's going to choose something that you hold really dearly and inject some doubt around it. So maybe your family is the most important thing in the world to you. So OCD says, yeah, but what if you hurt your family? You could hurt your family. Well, yes, of course you could. I could hurt my family too. I could walk out of this room, grab a knife out of the kitchen, and stab my husband. I don't want to. I'm not going to. I'm not really that concerned about it. But I have the ability. It's possible. It could happen. So I also want to say that everyone has intrusive thoughts from time to time. So human brains make intrusive thoughts. Everybody has intrusive thoughts. But OCD takes it a step further. And OCD says, wait, why did I just think that? Is there something wrong with me? And then you feel compelled to do something in response to that thought, either to prevent a bad outcome or just to feel less bad. So let's go back to this thought. Let's go back to this thought of stabbing my husband. And I'm just like, somebody's going to make a YouTube short about that and just post that piece of it. So let's just go back to that thought. Maybe I don't feel 100% certain that I won't do it. So I avoid the kitchen if he's in there. I let him take over any task involving a knife. If I'm in there and he asks me to cut some vegetables, I'm white knuckling it the whole time. I am constantly checking and scanning for any urge to hurt him, just to make sure that it's not there. So I'm going to share my screen. I'm going to show a graphic that I got from the International OCD Foundation, which is a fantastic organization. They have a great website, lots of good information. So I'm going to, okay, here we go. And share. All right, I'm going to make this a little bigger. So this is this is from the International OCD Foundation. This is how the cycle goes. So the whole thing starts with an obsession. So an obsession, it's usually it's a thought, but it could be an image or an urge, and it's recurrent and unwanted. It's not this one-off thing. It's happening a lot, and it's unwanted. So obsessions are, like I said earlier, they're jarring, they're intrusive, they're gross, they're disturbing, like we don't like them. So naturally, that obsession is going to cause some kind of distress. Maybe it causes anxiety or just some kind of discomfort or doubt. OCD is also called the doubting disease. So it's kind of like, but wait, what if this, or what if that, or what if I could do this, or what if this could happen? Or disgust. It also might be just thoughts that are really disgusting, repulsive, embarrassing even. So I have this, yucky thought that I don't like, which of course causes me to feel yucky inside. So then I do something. I need to do something to either just to feel, I say to feel better, it's really to feel less bad. It doesn't really make you feel good, but something to deal with this. I feel this anxiety, this doubt, this disgust. I don't like it. I don't want it. I got to get rid of it. So then you do something to try to feel less bad. And some of the really common ones are things like checking or seeking reassurance. There's other ways it could go, but a lot of the time it's some version of like, okay, but are you sure? Am I sure? Are you sure? Are we really sure? Are we really sure? What about now? What about now? And it ultimately really never gets satiated, except in the very short term. So I check. I'm like, okay, do I have this urge to stab my husband? Okay, no, I don't think I do. Okay, I think I'm good for now. So that I get this little bit of, okay, there's some relief. I feel a little bit better. That kind of helped. And unfortunately, what you learn there is that the reason you didn't do that awful thing is because you checked. It's like, oh, well, I didn't do it. It must have been because I checked. It must have been because I prevented it. It must have been because of this thing that I did. So you get this little tiny piece of relief. And then the whole process starts all over again with the next intrusive thought. And it's distressing. And I have to do the thing. And I feel a little bit better. But then the next, and then over and over and over. So compulsions will eat up so much of your time. Like it could be hours out of your day that these things are eating up. So that's kind of how the cycle goes. All right, I'm going to take that down, and I'll be sharing other stuff as we go. But I want to say that again, compulsions don't make you feel good. They just make you temporarily feel less bad. So now I want to talk about kind of the different flavors of OCD. And it's not just contamination. So OCD has really quite a variety of subtypes, and we don't officially diagnose the subtype. So the diagnosis is OCD, like regardless of what the subtype is. But the subtypes are really helpful in understanding what's going on with somebody and understanding all the different ways that this can show up. And this is where I think things can be really surprising for people. So contamination is a subtype. So these are, the hand washers, the cleaners. It is a way it can go. And in the case of this, with that cycle, the obsession might be something around like dirt or germs or contamination. It might be, what if I get sick? What if I get other people sick? So that's the fear. or that's the thought. It prompts this fear. So then the compulsion, the thing I do to deal with that fear might be hand washing, it might be cleaning, it might be checking. But you might say, okay, but there are germs out there and it's good to be clean. Where's the line? Which yes, that's a great question, because I'm not going to come in and say, never wash your hands ever, or go lick toilets, or anything like that. Like there is some like prudent, cautious kinds of things. But OCD is excessive. OCD is time consuming. OCD is distressing. So people with OCD don't want to care. So if somebody is like, yeah, I do this thing, I like it, it's fine, I think it's good, I think other people should do it, that's not OCD. So just wanting things a certain way, that's probably not OCD. If the person's like, no, this is just how I like it, and this is fine, and it doesn't cause any distress, that's not OCD. OCD is, I hate that I do this. I wish I could stop. It's so stupid. I don't want to care. I hate doing this compulsion. So let's talk about a few other subtypes, knowing that this is not an exhaustive list. So the example I gave earlier about stopping my husband, that would fall under what we call Harm OCD. And Harm OCD, I don't have any hard numbers off the top of my head. I'm sure I could Google it. It's not uncommon. It's a lot more common than people think, I would say. So this is that you're having an intrusive thought. You have an intrusive thought of harming yourself or harming other people. Or it could be an image. It could be an image of harming yourself or harming other people. Or it could even just be a behavioral urge. Like you just kind of feel this urge to like push somebody off a balcony or grab a knife or whatever it is. So I really want to emphasize that if you have Harm OCD, the last thing in the world that you are likely to do is harm yourself or harm another person. In fact, you could actually trust a person with Harm OCD with your life, with your child, with your elderly mother. They don't want to harm people. They don't want to harm themselves. In fact, they probably have a really strong value around life or health or whatever is the opposite of harm. And OCD is just taunting them like it does. So another subtype is what we call Scrupulosity OCD. So this might or might not have religious themes, and it might have religious themes even in a non-religious person. So kind of this example that I give. So I have this memory. I can't find this clip anywhere, but I swear I remember watching an interview with Howard Stern where he describes himself as a religious paranoid. And he says that he doesn't think he believes in God. He doesn't think that that's really what's going on. But he doesn't want to go so far as to call himself an atheist or like say unequivocally that God doesn't exist, because what if I'm wrong? And what if there's repercussions for that? So he's kind of like, this is like what I believe, but I'm not going to like stand by it because what if I'm wrong? And I don't know, like there's uncertainty. And so I think it was Howard Stern. I might be getting him confused with somebody else. And I've tried to find that on YouTube, but I've not had any luck. So, but that's kind of an example of like, okay, but what if I'm wrong? What if I'm wrong and I speak it into existence and then something terrible happens? Or somebody might fear offending their God or getting into legal trouble or doing something morally wrong. And so the compulsion, where that shows up, it might be to like to confide in your faith leader or confess to other people, or sometimes there's even this urge to just like go to the police and just be like, we're good, right? Am I good? We're good. Like we're good. I'm not in trouble for anything. And I want to say that this really gets in the way of people practicing their faith. So this really isn't like it's OCD. It's not practicing your faith, and it really gets in the way of being able to enjoy the benefits of practicing a faith and being part of a faith community. And so I'm certain there are faith leaders all over the country who have people in their congregations who are like, like if they're Catholic, they're constantly coming to confession or kind of whatever that process is. And it's never satiated, because then the next doubt comes along, the next thought comes along, or the next uncertainty comes along. And then finally, I'll say that OCD can take on some really kind of taboo forms. So people might have thoughts of harming a child or saying or doing something that's very hateful or bigoted. People might have unwanted sexual thoughts about a family member or a coworker, or people will have a fear that they're not actually straight. And so this is where I'm going to say finding a provider who specializes in OCD, because there's nuance here. I mean, obviously there is exploring your sexuality, and then there's like what we would call homosexuality OCD, which is not the same thing. So finding a provider that really specializes in OCD, they can kind of tease out, okay, what's just normal? You're exploring who you are and you're trying to get to know yourself better, versus you have this like compulsion and this obsession that can never be satiated. And so it can take on some really kind of darker, more embarrassing, more taboo kind of forms. And that's not terribly uncommon either. Okay. So I want to talk now about what are compulsions, and delve a little bit more into that. But I am going to say, if you've found this interesting so far, or if you've had any sort of aha moments, or you'd like more of this type of content, don't forget to subscribe to the channel. I post content I have 5 specialties as a therapist. OCD is one of them. The others are sleep, chronic pain, radically open, DBT, and PTSD. Okay, cool. So a compulsion is a behavior. It's a thing that you do in response to the obsession, to the thought or image or urge. You feel compelled to do it. You feel like you have to do it. Like you can't be okay unless you do it. And it makes you feel a little less bad. Doesn't really make you feel good, but it makes you feel a little bit less bad. So the compulsion it may seem logically connected to the obsession. So maybe I have a fear of germs, so I wash my hands. Or it might not make a lot of sense. Like maybe I have a thought about harm coming to a family member, and so I have to turn around 7 times to make sure that doesn't happen. So it might have like seemingly no logical connection. And most people with OCD are like, I know this is crazy. I know this doesn't make any sense. Like this isn't, they you don't actually think that this is linked to that. But there's just this like extreme intolerance of doubt, of uncertainty. The stakes feel really high. Like if you're worried about harm coming to somebody that you love, and turning around 7 times could prevent it. Okay, well, I can do that. That's certainly better than something bad happening. Compulsions can be internal. So we call this pure O, although it's kind of a misnomer, because like pure O makes it sound like you just have obsessions, when really you also have compulsions. The compulsions are just internal. They're not observable. So maybe think of this like washing your brain. So it's an effort to find certainty. It's a thought or some kind of a mental thing that you feel like you have to do. And what you're trying to do is find certainty. So sometimes these are even things that maybe a therapist has told you to do, or things that seem like they would be the right thing to do. So any like healthy coping skill can turn into a compulsion. One example is self-reassurance. So, maybe you're having an intrusive thought of, what if I could harm my family member? So then you start telling yourself, okay, but I don't want to do it. I've never done that before. I've never done anything violent. I know I don't want to do it. I know I can, which sounds like that would be helpful or sounds like a reasonable thing to do. And it can be a reasonable thing to do. It just doesn't help OCD. Like it doesn't work with OCD because it just keeps like feeding that cycle. Or it might be trying to replace the thought with another thought, like trying to neutralize the thought. Now there's therapy where we literally do that with people. We call it cognitive restructuring. And somebody has a thought that isn't 100% true. And so we kind of help, let's challenge the thought. Let's try to come up with another thought that's more adaptive, more realistic. That is done in therapy, and that is helpful for some things. Like it's helpful for generalized anxiety. And I'm going to link a blog post down below where I get into like what is the difference between anxiety and OCD. How are they the same? How are they different? How do they relate to each other? But we do that sometimes with some things, and it can be helpful. It's just not helpful with OCD. It's not helpful with OCD. Trying to like find evidence, like trying to logic your way out of it doesn't help for OCD. So what does help for OCD? Well, exposure and response prevention, or ERP, which so ERP stands for exposure response prevention. You might also hear it called exposure and ritual prevention. It's the same thing. It is the gold standard treatment for OCD. So what does it mean to be a gold standard? I know you heard me use that term earlier. So in medicine, we call something a gold standard if it is considered like unequivocally the best in its category, and all other things in the category get measured against it. So that's a gold standard. So for OCD, the gold standard is ERP, exposure and response prevention. So the treatment is actually pretty straightforward and simple. It's not easy, but it's simple. You face the fear and then you don't do the thing. So by not doing the thing, you learn a few different things. One thing you learn is that this feared outcome doesn't happen even if you don't do the thing. And you also learn that you are able to tolerate the distress that builds up when you don't do the thing. And that the distress doesn't last forever. Again, even if you don't do the thing, the distress comes down on its own. So we are breaking that cycle, that circle thing that I showed you earlier. ERP it's a structured and manualized treatment. So this means that there is a protocol to follow, and there's a right way to do it. So I'm going to say be wary of anyone who is not doing it like by the book. And there literally is a book. It is. Let me get this in frame. It's this right here. This is this is the manual. So this is the therapist guide. This kind of walks you through everything to do. Now I want to say don't, just reading this is not sufficient. You also want to have had a pretty thorough training in how to do this and how to diagnose OCD and what to look for. But this is the guide that I use that kind of walks you through everything. There's also a client workbook right here. So this is the client workbook that kind of walks the client through everything. But there's a book, and you follow. I mean, I follow the book. And with any treatment that is considered evidence-based, and ERP is most definitely an evidence-based treatment, the practitioner really needs to be faithful to the treatment model, or it's not going to work. So there's a process to follow. There's steps. Anyway, I think that's all I need to say about that. I also do want to acknowledge that there are another kind of, I don't know if it's like what the right, medication is also a treatment for OCD, like as far as the first line treatments, ERP, and then certain medications. There are medications that can help with OCD symptoms. Typically the medications that we call serotonin reuptake inhibitors. So these are medications like Prozac, Zoloft, Alexa, there's a whole bunch of others. It's like the medications that you often see prescribed for depression or anxiety. So that is also a treatment for OCD. Kind of my understanding of it is I don't think you're going to get full remission with just medications. You can get full remission with just ERP. And then for a lot of people, they're going to do really well with a combo of some kind of serotonin reuptake inhibitor medication and ERP. So the International OCD Foundation, which I'll link below, has a fantastic resource where they walk you through, here's the first line treatments, and then if those don't work, here's what you do. If those don't work, here's what you do. It kind of walks through treatments that are not helpful, treatments that could be harmful. It's a really great kind of thorough resource. So I'll make sure to link that below. So what does ERP entail? What does it look like? The 17 to 20 sessions is kind of the average length, but somebody might need fewer or more depending on their situation. So we start with an assessment, of course, to be absolutely, or I say to be absolutely certain. I just saw what I did there, because wait, we're trying to get away from absolute certainty. Reasonably certain enough that somebody has OCD. So the treatment for OCD is really specific, and other approaches that work for other types of disorders can actually make OCD worse. So you do want to be certain that yes, this is OCD, not some other thing that looks like it. So that's where we start, is let's just kind of assess what's going on. Let's try to be reasonably certain that yes, this is OCD. Then what did I just do? Okay. So then there's some education about how OCD develops and what maintains it. So kind of talking about the theory. There's a lot of explaining the rationale for the treatment, because understandably, people, you want to know why you're being asked to do what you're being asked to do, especially if what you're being asked to do is really difficult or makes you really uncomfortable. So there's lots and lots and lots of explaining. Here is why I'm asking you to do this. Here's what the benefit's going to be. So then you will work with your therapist to build a list of exposures, starting with easier ones and working your way up to harder ones. This is going to be tailored to your specific situation. So you're going to be tracking, once treatment gets started, your therapist is going to have you track triggers that come up, and then what you the compulsion that you did, how long it took. So then you have a pretty good idea of what's actually coming up for somebody, what's going on, what kind of stuff do we need to put on the treatment plan. So I'm going to show a couple of other things that I think might be helpful. So we use something, let's see, I'm going to share this again. So we use something called the SUDS, or Subjective Units of Distress scale. So this is just a way of trying to put a number on how bad you feel. And so it's either 0 to 10, or it could be 0 to 100. And I will come up with anchor points for people. So I'll ask somebody a SUDS of 0. No distress at all. You feel great. It's your happy place. What is that for you? So this is another sample from the International OCD Foundation. Relaxing by the ocean might be, that's a 0. Okay, great. What's a 10? What's the most distressing thing you could ever imagine in your life? This example is trying to escape a house fire. Then you try to think about, okay, what's in the middle? What's a 5? So that's going to be something that's not as distressing as this 10, but it's something that's distressing, but you feel like you could handle it. You feel like you could kind of muddle through it. And then now you've got these anchor points. So then when you start looking at what are the triggering situations, is it more or less distressing than any of these? Okay, so then here is an example of an exposure hierarchy. So this is the thing that you're gonna put together with your therapist based on what are the situations that are upsetting or triggering for you. and you rate them from lowest to highest. You put them in order. So this is actually this example is somebody with Harm OCD. And so holding a butter knife while alone in the house is okay. That's only at a 2. And then it kind of goes up. So butter knife while near family is a little bit more distressing. Cooking with sharp knives while the family's in another room. Recording and listening to a script. I'll talk about what this is here in a second. Cooking, holding a knife, and then holding a knife while listening to my script. And so how this would work is you would start at the bottom, either at the 2 or the 4, kind of depending on you'd talk to the person, kind of see what they want to do. But you might have them just practice holding a butter knife while they're near their family. And that's what they do. They just sit there. And you typically do the first exposure in session. So this might be something where you might see if like the family could come in, or if you're doing virtual, have the person kind of take you with them on their phones. But you would do it. You would be near your family and hold butter. And your therapist is going to get a SUDS rating. So let's say you say it's a 4. And then that's kind of what you kind of just do that. You just sit there and you hold the knife, and your distress is probably going to go up. It's really common for this to go up. And while that distress is going up, your therapist might ask you, what is your OCD telling you? And your OCD might be telling you, this is really dangerous. You're going to hurt somebody. You need to put the knife down. And then you're like, you acknowledge it, and then you check the SUDS. You check the SUDS every few minutes. And what the therapist is not going to be doing is anything like reassurance or really anything to try to bring the anxiety down prematurely. We want it to go down on its own, because what is going to happen, what I've seen happen, this is how it happens, is the distress does go up, and you're sweating it for a little while, and you have strong urges to do whatever it is, to check, to put the knife down, to back out. But what happens eventually is that distress will crest, and then it will start to come down on its own without you having to do anything. And it will come down, and it will come down, and it will come down. It's going to go like this, and then on its own. And then once you've kind of gotten through that, people feel so relieved. They feel so proud. And you learn that, okay, I can sit here and I can hold a knife and nothing happens. And I'm able to tolerate the distress. And then the next time you encounter a knife, you're not as distressed about it. It doesn't bother you as much. And then you just work your way up. So then the next thing I might have you do this, and same process. You just face the fear, and you don't do the thing. Record and listen to a script. Let me talk about what this is. So there's 2 different types of exposures. There's what we call in vivo and what we call imaginal. In vivo is doing it like in life, in real life. So holding a knife, cooking with knives, those are in vivo exposures. Imaginal exposures are something that you do when it just really wouldn't be a good idea to actually do the thing. So obviously, you're never going to ask somebody, hey, why don't you go harm your family for real? And then we'll talk about it. Like, for a variety of reasons, you're not going to do that. But there's a way of facing that fear, and it's to write out a script of your worst nightmare. What is your worst nightmare? What are you afraid of? So you write down, here's what I'm afraid I'm going to do. Here's how this could go. You write out the script, and then you read it out loud, and your therapist is going to check your SUDS rating. And then you're going to read it again and check your SUDS, and read it again and check your SUDS. And you just read it over and over and over and over again. And the same thing is going to happen as with the other one. So it's going to be distressing. It's going to get more distressing. You're going to have urges to quit or to check or to do whatever it is you normally do to feel better. And then after a few times, what happens is people start to notice, okay, I'm not feeling as, it's not bothering me as much anymore. The sting is out of it. It's not as distressing. And at some point, people are like, I'm kind of bored with it now. To which I'm like, great, that's the goal. So then the next time this person has a thought of how they could harm their loved ones, it's just not going to bother them as much. They're going to be like, no, I don't know. Maybe I will, maybe I won't. I don't know. And they go about their day. And that's basically how the treatment works. And you just kind of keep working your way up the list. New stuff might get added because it can shapeshift. Sometimes the OCD can shapeshift, so new stuff might get added. But that's kind of a lot of what to expect. So there's also a tool, like how do we know it's working? I mean, we ask people, how are you feeling? Of course, that's part of it, but there are also objective ways to measure progress. So there's a tool called the Y-Box, which stands for Yale-Brown Obsessive-Compulsive Scale. It's used to help diagnose OCD, and it's also used to help measure the severity of it. And so you ask questions about how frequent are you having the obsessions? How much time are the compulsions taking up? How distressed are you about it? How disruptive to your life is it? All these different questions. And then you get a number. And then you watch that number drop as you go. And then also, kind of what we're looking for is for the compulsions to be happening less frequently, like the amount of time you're spending them. And really what we're trying to do is get rid of the compulsions entirely. But early on, we're just looking for them to be less frequent, less time consuming. And then we're looking for the compulsions to stop. And then we're also looking for the triggers to get less upsetting. So people get to the point where they have this upsetting thought and they're able to shrug it off and just be like, I don't know, maybe, they're like, you're learning to live with the uncertainty. So maybe it will, maybe it won't. I don't know. So my last point here is just to talk a little bit more about how OCD gets diagnosed. So how we do mental health diagnoses is using, this is the most recent edition of the DSM. It stands for Diagnostic and Statistical Manual. And then we are in the 5th edition text revision. So there was a DSM-5, and then now we're in the DSM-5 text revision. So the next one, I don't know if it's going to be DSM-6. I don't know. We'll have to see. But we have this manual for better, for better or for worse. This is the tool that we have to try to diagnose what is going on with somebody psychiatrically. Now, psychiatric diagnosis can be a little bit of a moving target. It's not as exact as other diagnoses in other areas of medicine. It's not like you can just check a blood level and be like, okay, well, if it's over this number, it's diabetes. If it's not, then it's not. Disorders get reclassified, disorders get added, they get taken away, criteria changes. OCD actually used to be categorized as an anxiety disorder. But now we have a category called obsessive-compulsive and related disorders, because OCD is not always, some people with OCD feel anxiety, but some people with OCD feel disgust. It's not always anxiety. So now we have this category, which is obsessive-compulsive and related disorders, that includes OCD, but also includes, there's other things that show up a lot in people with OCD that don't show up as much in people who don't have OCD. So like hoarding disorder is an example of something that can show up in the same person. There's something called body dysmorphic disorder, which I'll just briefly define. Morph means form. So body dysmorphic disorder is something about there's something about my body that's formed wrong. And it could be your nose, it could be your leg, it could be any part of your body. but you've kind of just got this idea that something about your body is like formed wrong. And so there can be, I mean, this, I think this might have been what was happening with Michael Jackson, and why I don't know for certain, but he kept having those surgeries on his nose and just kept having more and more surgeries. Like, I wonder if he had this idea that something about his nose was wrong, and he was just like trying to fix it, trying to fix it, and trying to fix it, and it just would never get fixed. So that's body dysmorphic disorder. And then something that we call BFRBs, or body focused repetitive behaviors. So typically this is going to be hair pulling and skin picking. Now, lots of people do this. It doesn't always rise to the level of a disorder. Lots of people pull hair and like pop sits and stuff like that. But for some people, it can get to the point where it's like they're leaving scars, they have bald spots, they're really embarrassed about it, they're trying to stop and they can't stop. And so those are, so that's how OCD is in a category with those other things. And lots of people with OCD might also struggle with one of those other things that I just listed. So to diagnose OCD, we are looking for both obsessions and compulsions. So technically, the DSM actually says you can have obsessions or compulsions, but pretty much the standard wisdom in the field is if OCD is obsessions and compulsions. So somebody does not have compulsions, consider some other explanation. So we're looking for both obsessions and compulsions, keeping in mind that the compulsions could be internal, they could be other thoughts. And then we're also looking for the compulsion to be in response to the obsession. They're tied to each other. I have this thought, it creates uncertainty, I don't like it, I do this thing to feel better, I feel better for a little while, and then the thought comes back. Also looking for the compulsions to be time consuming. So more than an hour a day is kind of the cutoff that we use for what's time consuming, what's a problem. So looking for that to be time consuming, or looking for it to be really distressing, like looking for it to be like, I hate that I do this, I don't want to do this, I don't want to care, it's eating up so much of my time. So we're also looking for it to be really distressing or really impacting your ability to live your life. So maybe it's, you can't get work done, you can't care for your kids, you can't, yeah, I mean, and it can even be to the point where people can't, like, it could be really disabling where people can't work, where they can't function. So it doesn't have to be every single one of those, but we're looking for like at least one of the three. Then you're also going to rule out that the symptoms aren't attributable to a medical condition or a medication side effect or a substance like drugs or alcohol. So you always want to make sure, so just a good practice with mental health is just kind of rule out any other kind of medical stuff. And then finally, you want to confirm that this is truly OCD and not something that looks like it. And just like any other area of medicine, a proper diagnosis really leads to the proper treatment. And a misdiagnosis can can like you end up wasting a lot of your time and a lot of your money going down a path that's not helpful. It's pretty rare to just have OCD. There is very frequently some other diagnosis in the mix there. So a lot of the time it's depression, it might be generalized anxiety disorder, it might be an eating disorder, or it might be like hoarding disorder, one of those other things I mentioned earlier. So again, this is where it's really important. Not all therapists are OCD specialists. So because it's so, and an OCD is sneaky. It can shapeshift, it can look like other stuff. So a licensed therapist who specializes in OCD. So look for somebody who has been trained in like exposure response prevention. There's some other treatments that are kind of coming onto the field for OCD, but ERP is but anyone who's doing any of those other treatments, I think they should be trained in ERP, have done ERP, So really look for somebody who specializes in OCD, who has specialized training in treating OCD. So that person can really help you tease out what's what and help you decide what to tackle first. Maybe you do have OCD and what we call generalized anxiety. And the treatments, there's some overlap, but the treatments are also really different for those types of things. So I've written a few blogs on OCD that I'll link below. And then I'll also say if you're located in the state of Texas and you think ERP might be a good option, I've got ways to contact me below. If you're not in the state of Texas, I will include a link to the OCD Foundation's directory so you can find somebody where you are. And I'll just explain real quick in case you're wondering, why does it matter if I'm in Texas? At least in the United States, the way licensure works for therapists is it's by the state. So you're licensed by a state, and then you can only practice in that state. So I am only licensed in the state of Texas. There are therapists that are licensed in multiple states, but for me to legally treat you, you have to be located in the state of Texas, like physically sitting in the state of Texas while we're having our sessions. Okay, so I hope this was helpful. And hey, if you made it all the way to the end, thanks so much for watching. All right, take care.